Hello, my name is Scott Lippman. I'm a medical oncologist and professor of medicine at the University of California at San Diego. I'm going to provide some answers to the most commonly asked questions in cancer. Who gets cancer? Everyone is at risk. Roughly 1 out of 4 people will develop cancer in their lifetime. And clearly there are certain behaviors and genetic risks that we'll get into that place people at higher risk to get cancer, but cancer can occur in people who have no risk factors at all, and we still don't understand how that works, but we're all at risk. How does cancer start? Well, cancer is basically a genetic disease, and so cancer starts from genetic alterations, mutations in certain genes that can cause cancer. There are 2 basic classes of genes, oncogenes and tumor suppressor genes. And when you have mutations in these genes, they can begin to start the development of cancer. But there are a lot of other aspects of the immune system and so on that will determine if the cancer fully develops or not. But it does start pretty much as a genetic alteration in your normal cells. Because some cancers are genetic, if one of my parents has cancer, will I eventually get it? Genetic or genomic can refer to alterations in genes in the actual tumor tissue or epithelial tissue, normal tissue in the body, or it can be inherited, or both. And so the inherited genetic factors are called germline factors that you inherit from your parents. And they can lead to blue eyes and different things like that. There are classic genetic susceptibility genes that increase your risk. Well known is BRCA1, 2, BRCA1 and 2. Angelina Jolie brought a lot of attention to this when she had developed cancer. But there are also alterations in genes that can occur only in your tissue, not that you inherit. And those are called somatic changes. And it's the combination of those 2. And so when we think about cancer being genetic, we're talking about germline inherited changes. Is cancer contagious? Generally not, but I guess indirectly it is, in the sense that there are viruses well known to cause cancer, and they can be passed contagious. So a classic one is HPV, human papillomavirus, which is transmitted by sexual contact. And so that would increase your risk. Doesn't mean you will get cancer, but in that case, its risk is contagious, we can put it that way. Is there a vaccine for cancer? And that ties to the contagious issue. Again, a classic current example is human papillomavirus. And there are several very effective vaccines that people should be taking to prevent HPV-related cancers. Those can occur in various areas. They can occur in a place in the head and neck cancer called oropharynx, which is sort of base of tongue. They can occur in cervical cancers, the one that's most common, in the cervix, in the penile area, vaginal. Those are areas where the human papillomavirus cancer is caused. And if you are vaccinated, it will greatly reduce your rate. And these are like childhood vaccines. The idea is to get them earlier. Initially, they were just recommended for girls because people, when they hear HPV, they think of cervical cancer. But now we know oropharyngeal cancer, which is a major head and neck cancer, can occur in men or women. So the recommendation is that all children should be vaccinated with HPV. The actual uptake rate in the United States is quite variable. And there's a lot of reasons for that, a lot of psychosocial, religious reasons for not getting vaccinated. But on a medical, scientific basis, I believe everyone should get vaccinated when they're young for this. Why is diagnosis generally so delayed? The symptoms and signs can be fairly nonspecific. So one of the questions relates to fatigue or weight loss, things like that, and even lumps or bumps can most commonly be due to self-limited or easily treatable infections, bacterial infections, with antibiotics and so on. And so often someone will come in, like I see head and neck cancer is one of my areas, will come in with sinus-like infection, and they can go on for months and months, sometimes a year long, with various courses of antibiotics until finally it's realized that it's actually cancer in the sinus area. So, it's delayed because the symptoms can be vague, and because all of us tend to put things off. We're busy, and so that's part of it. What symptoms of cancer should I be on the lookout for? The symptoms of cancer include fatigue, weight loss, and then dramatic ones. Coughing up blood is a major sign for lung cancer. For colon cancer, rectal cancer, black or sort of melena stools can be a symptom of that. Lumps or bumps or the signs. Basically, the rule of thumb is that if you have any of these symptoms, which can be nonspecific and most often due to inflammatory or infectious issues that will go away, it's persistence. It's not that you woke up and you're tired one day or something like that. If the symptoms persist and they don't get better, then you need to get in to see someone. When should I be tested for cancer? Persistent symptoms, you would come in and see a doctor, and then they can decide whether to test you for cancer. The important aspect is that once you get in to see a doctor, then things, if there's a suspicion of cancer, can move fairly quickly in terms of evaluating the disease and biopsying and so on. How can I prevent myself from getting cancer? We're all at risk, and there's no way to prevent 100% getting a cancer, but you certainly can greatly reduce the risk by not smoking or using tobacco, not having a lot of UV sun exposure, particularly as you're young, and some of the other sexual behaviors and things that I mentioned. So there's a lot you can do, really more avoidance ways to not put yourself at higher risk for cancer. Do we get cancer from what we eat? This is a difficult problem. There's a lot of interest in diet and vitamins in relation to getting cancer and modifying the course. And the data out there, the evidence is very difficult to come by. And so I think the risk of getting cancer from what you eat is very low. But if you eat, if you're overweight, so obesity and physical activity are major risk factors for cancer. So I think having some reasonable exercise schedule, walking and things of this sort, and keeping not getting obese will reduce your risk. The fact that there are certain things you can eat that cause cancer, they really aren't great examples of that. Can a change in diet alter the course of cancer? And that also is hard to know. It's very hard to monitor diet. There's surveys and questionnaires, but it's really hard to monitor because diet is so complex and it changes a lot. And so, can a change in diet alter the course? I would say the same types of things. There's some evidence that people who've had cancer, particularly breast cancer, ovarian cancer, that if they maintain an exercise program, physical activity, watch their diet in terms of their obesity and their what's called the BMI, the not being overweight, if that's an issue, then by watching your diet, not being overweight and exercising can alter the course, improve the course of cancer in some cases. With so many advances, why isn't there more progress? I think that this is an interesting question. There have been many advances, but cancer, the more we learn how complex cancer is. There's so many causes, there's so many genetic and immune and other aspects of cancer. Since when precision therapy started, really in the late 1990s with HER2 and Herceptin, that led to a way to treat initially breast cancer that had this genetic alteration. And so it can help, but the more we study the genetics and the biology and the immune aspects of cancers, the more questions that occur, the more subtypes. And so it just seems like the more you learn and dig deeper into aspects of cancer, it becomes more complicated. I mean, just an example on the immune front is people studying macrophages and their relation to cancer. It's a type of immune cell. And for many years, people thought there were just two types, M1 and M2, one was good and one was bad. And now there are multiple different subtypes. And so sorting through those layers of complexity has been challenging and delayed some of the clinical progress a bit. Why do people with the same cancers receive different treatments? The general diagnosis of a cancer like breast cancer and colon cancer and ovary cancer that we know based on genetic studies and other biologic studies that there are multiple subtypes of cancer. A good example would be lung cancer. Initially there were two types of lung cancer. One was called small cell cancer and the other non-small cell cancer. And now we know that even with the one subtype, adenocarcinoma of the lung, there are probably 30 different subtypes. So if you can envision a pie and then different aspects of the pie, you have 1% of patients have what's called ROS1 mutations. A couple percent will have RET mutations. So, and that's how we treat. We treat based on these genomic subtypes. And so, so that literally patients with lung adenocarcinoma can end up with very different treatments. Even though they have the same tumor, they have different genomic subtypes. And that's how we treat patients. That's basically what precision oncology is, and that is doing testing of the tumor, molecular profiling or genomic tests, and determining what is driving that tumor, what genetic alterations, and the treatment is targeting those. How do cancer drugs work? In different ways, but in precision oncology, which is really, again, what I mentioned, started in the late 90s and is rapidly transforming the treatment, the landscape of treating patients. You're targeting certain alterations in the tumor, and a classic, in fact, the first example of precision oncology in the late 90s was the identification of a gene called HER2, amplification that drives a certain subtype of breast cancer. And if you use a drug like Herceptin that targets that alteration, HER2, women can get very good responses. And it's similar in lung cancer that have EGFR mutant tumors, targeting EGFR and so on. Should everyone get a second opinion? I don't know if everyone should, but you certainly, I think, these days want an opinion from, I would say, from a major cancer center, like an NCI cancer center. Given the fact that the field is changing so dramatically, and in an academic setting, you tend to get experts in certain tumors, and they know all the different aspects, which is hard to keep up with if you have a very busy community practice. So I think getting a second opinion is generally good, but you can overdo it. In some cases, well-meaning friends will recommend a lot of different opinions, and that can get counterproductive at a certain point. Can fatigue from treatment be prevented? Not easily. There's no great treatment to minimize or prevent fatigue. Again, physical exercise and things of the sort clearly can help. But fatigue, just like weight loss or cachexia due to cancers, can be very severe, and the best way to prevent or reverse fatigue or weight loss from the cancer is to treat the cancer, and when patients respond, they do well. And that's fatigue from the cancer. Fatigue from the treatment is can prevent, improved in some ways. For instance, keeping people hydrated, intravenous hydration while they're getting therapy, and so on. And that can help sometimes. Will my hair grow back? In every case I can think of, after the treatment stop, the hair will generally grow back. The reason people can lose hair and have hair loss with certain types of chemotherapy is that it turns out that the hair follicle cells are one of the most rapidly dividing cells in the human body. And the same is true actually for bone marrow cells. And some chemotherapies work by attacking cells that divide rapidly, tumor cells. Tumor cells generally divide faster, multiply faster than normal cells. And so the hair is at risk from sort of general chemotherapy because they divide quickly, but generally the hair will go back. There are people that say when their hair goes back, it's different, maybe curlier or something, but I haven't seen any real studies on that. Why isn't there a universal test for cancer? Because the tests are different for different tumors. But I will say that in the era of precision therapy, which began in the late 90s and literally over the past 5 years, the number of what we call actionable genomic alterations has increased 4-fold. So it's really taking off. And more what we're recommending when we diagnose cancer and you biopsy the tumor is getting what we call next-gen sequencing panel. So in that case, there is kind of a universal test because those genomic panels or genomic tests look at a lot of different genes. The issue of the testing, which is maybe related to one of these questions, is that although we know what tests to get, a big challenge in the field of treating patients with cancer is that when someone actually has symptoms and they eventually get in to see an oncologist, the oncologist will order scans and different types of tests and blood tests to evaluate, this is one of the questions, will evaluate the extent of the tumor. Kind of related to the last question, how close are we to curing cancer? Again, cancer is not one thing. There are multiple subtypes within even the same tumor site, like breast or lung or so on. But I will say that advances in precision therapy and immune therapy are moving very quickly. And I think we're getting closer and closer to curing a larger percentage of patients with previously incurable metastatic disease. But I guess I would say that the biggest hurdle right now to making that happen is figuring out a way to get the genomic information that we know is helpful rapidly to avoid patients having to delay therapy. And I mentioned 4% of lung cancer die per week. Many more of those patients become too sick to get therapy. So this is a big challenge. It's being able to implement what we already know, but we need to get that information much faster. And innovative ways with AI are making major strides in that sense.